Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today my topic of discussion is about choroidal melanoma. Choroidal melanomas are the most common intraocular tumor in adult population. If we generally talk, they make about second most common in general population after the metastasis. And that usually take origin from the uveal melanocytes. And the demarcation line is equator. Anterior to equator, the tumor of uveal can involve ciliary body and iris, but these anterior tumors of the uvea make about 15%, not more than that. But if we talk about the posterior one, these make 85%. And these take origin from the uveal melanocytes. About its different classification histopathologically, it may consist of type A spindle, spindle type B, then we have got mixed type, fascicular type, epithelioid, and the necrotic type. It's fundoscopically, its findings, it is maybe grayish to brownish in coloration, and they may sometimes be amelanotic. As compared to choroidal nevi, they are 2 mm elevated. There may be associated exudative retinal detachment, and there may be lipofuscin pigments over there in the choroidal melanoma. The collaborative ocular melanoma studies, they have some very important distinguishing features in which they have made it small, medium size, and the large size. And they kept two things over there. One is the apical height and the second is the basal diameter. For example, if the apical height is 1 to 2.5 millimeter and the basal diameter is 5 to 16 millimeter, they consider it the small one. And the large one over there has the apical height of more than 10 millimeter, while the basal diameter is more than the 16 millimeter. So this differentiation of collaborative ocular melanoma study is very important when we are deciding the different treatment strategies. The physical examination on fundoscopy, the most important thing which helps us in diagnosis is the ultrasound, A scan and B scan. On the A scan, we will see usually a moderate, low to moderate hyperreflectivity. And if we talk about the B scan, we will find over the typical collar stud appearance, we can see exudative retinal detachment, choroidal excavation, and acoustic hollowness that can also be appreciated in A scan. So the most important thing which helps us in the diagnosis is the ultrasound, because it tells us exactly the height, apical height, basal diameter, and all these characteristic features of the choroidal melanoma. If we talk about the fundus fluorescein angiography, it may be hypofluorescent because of the pigmentary changes in the choroidal melanomas. But sometimes there are hyperfluorescent dots over there, and these dots are basically because of the lipofuscin deposition over there. And also sometimes in choroidal nevi, if we find out these pigmentary focal points of the hyperfluorescence and other features are also present in ultrasound, this gives us a very high suspicion of the neoplasm. Apart from this, as we know, there is one circulation going on the retina. The second is the choroidal melanoma circulation. So this is a double circulation. And this is a very characteristic feature of the choroidal melanomas, which can be appreciated on indocyanine green angiography. Apart from this, if we talk about OCT spectral domain, it can basically show us neurosensory retinal changes or retinal pigment epithelial changes, because they cannot penetrate deep down to this structure. So it can also show you exudative retinal detachment. When we receive such patient, we have to think about the metastasis also. And its metastasis is through the hematogenous route, and it can metastasize to the livers, lungs, and even skin. So any patient coming to us, we should go for the CT scan, chest, abdomen, and the liver function tests, very important. And even if we need PET scan, we can go also for that. To rule out metastasis is very important, because after that, the treatment strategy is changed. and the prognosis of the patient is also affected with this. So we have to keep all these things in the mind when we are going for the screening of the patient. On the size, as I mentioned, it is whether it is small, medium size or large, or whether it has metastasized or not metastasized, the surgical options are there. The classical approach was go for the enucleation, but depending upon the size, eye salvaging procedures can also be done. For example, plaque radiotherapy. Apart from this, also can particle beam radiotherapy and local surgical resection, along with the transpupillary thermotherapy and lasers use. All these can be done, but it all depends upon the classification, at which stage the patient has presented to us. About the uveal melanomas, 50% of these metastasize, and the liver is the most common site where it gets involved. And if we talk about the mortality rate, 15 to 20% is the mortality in the first 5 years, and the 45% mortality in the 15 years. So it is quite an aggressive tumor and infiltrating other organs also. It's our case. This is a 40 years old lady who presented with a vision, counting finger, anterior chamber was unremarkable, no findings, cornea, AC, lens, normal. But on fundoscopic examination, we found this elevated growth, dome-shaped in the posterior hole. And you can see over there that it is bulging forward. And if you look at number 1, this is choroidal melanoma. But if you look please at number 2 and 3, this is the retinal detachment over there, exudative in nature, which can be shown. So this is the fundus photograph of our patient, that 40 years old lady who presented to us. Otherwise, systematically, there was no other complaint of this patient. Come towards the ultrasound findings, which has a very important role in the diagnosis of choroidal melanoma. If you please see this ultrasound, the blue arrows over there are showing a central dome-shaped elevation in the posterior retina. This dome-shaped elevation is basically the choroidal melanoma. If you please concentrate at the red circles and a red arrow, this is the exudative retinal detachment, which happens with the choroidal melanomas. And now we come towards the A scan in the number 3 green section. Here you can see the first initial spike, and then after that there is a portion of internal hollowness, and after that the waves show low to moderate hyperreflectivity. Yes, these are the features very important and related to the choroidal melanomas. So B scan and A scan combination with this and these characteristic features help us a lot in the diagnosis of these types of tumors. This is another magnified images. In the left side you will see that blue number 1 is the exudative retinal detachment, which we saw earlier on the fundus photograph inferiorly. And the red number 2 in the left is the mushroom growth over there of the choroid. Yes. And in the right photograph, which again the blue brackets over there, they show you the exudative retinal detachment. And if we go towards the A scan inferiorly, you can see that there is hyperreflectivity is moderate. We can say it is not very high, it is moderate hyperreflectivity. Towards the ultrasound report, so the measurements was that its diameter was 19 millimeter and elevation was 7.75 millimeter. So it was large size choroidal melanoma as per our classification, dome shaped, detected infratemporally, and medium to low internal reflectivity with exudative retinal detachment, which was inferiorly from 3 to 9 o'clock meridians. And they mentioned it that it is choroidal melanoma as per the ultrasound At fundus fluorescein angiography, as I mentioned earlier, they may present hypofluorescent because of the blockage of the dye because of the pigmental changes, and sometimes there may be pinpoint hyperfluorescent dots-like appearance. So if you kindly have a look at this first fluorescein angiograph, you will appreciate that over in the macular area, you will find those small hyperfluorescent areas. Fundus fluorescein angiography, in the red circle, it has been marked how in the macular area these hyperfluorescent dot-like appearance is going on. And even in the other photograph, you will see how the staining pattern of it. Typical characteristic feature of this, you can see that the staining pattern is there in both these slides. And it is not going beyond the macular area. It is confined to that macular area and focal areas over there of hyperfluorescence. Fundus fluorescein angiography photograph. Here you can see characteristically that pinpoint hyperfluorescent dots-like appearance. And these dots are because of the lipofuscin pigments, which is the characteristic feature over there of these types of the melanomas. Talk about this particular case, its management. Once we received this patient, we started his blood works and investigations. The patient underwent chest CT scan and also liver, and to rule out any metastasis over there. Along with that, we also did her liver function profile to find out any changes over there, which was normal. Even the CT chest and liver was normal, no growth, nothing over there was found. And apart from this, we also did the ultrasound of the abdomen. So after this, the question was how to manage this patient. To make the final diagnosis, we had to go for the biopsy from the choroid. So for that, pars plana vitrectomy was done, and the sample was taken from choroid and sent to the laboratory for diagnosis, and it was confirmed that it was an epithelioid type of the choroidal melanomas. As I mentioned, these epithelioid melanomas make almost 87% of these choroidal melanomas. So after discussion with the patient and consultation, this patient underwent the enucleation. Yes, usually in these patients, as I mentioned, brachytherapy is an option or the enucleation. So it depends upon available resources, whatever you have, because this tumor has not yet metastasized. So, but it was a large tumor. So the patient underwent enucleation, and once the enucleated, and it was again histopathology was done, and it was confirmed that again that this was a large size choroidal melanomas. So once it was removed, the patient infection, nothing like that, then we have to think about the cosmetics, oculoplasty departments, putting the prosthesis and all these things. But these patients need regular follow-up for any metastasis. Yes, they have to undergo routine checkup, routine ultrasound abdomens, even sometimes they have to undergo MRIs to rule out any liver metastasis, any involvement of the lung. So because the mortality rate, as I mentioned, is quite high in 5 to 15 years after diagnosis. So it was very interesting patient which I wanted to discuss with my respected audience, and I hope it will be very beneficial in your clinical practice. I want to thank you for your attendance and attention. Thank you.